Good evening, everyone, and welcome to the Live Yes RA Goal Setting event. My name is Barry Lynch, and I've been living with rheumatoid arthritis for 8 years. When I was first diagnosed with rheumatoid arthritis, like many of you probably do now, I had a lot of questions. How would this new diagnosis impact my life? And while I know firsthand how overwhelming and confusing a diagnosis of RA can be, I'm here to tell you that you have more power than you think. There are so many things you can do to take control of your arthritis so you can live a fulfilling, productive life. And I'm proof of that. I continue to be able to do the things that bring me joy. I'm able to continue my work as an analyst, spend time with friends and family, exercise, take nature hikes with my husband and our dog. Empowering myself by learning about my disease and working with my healthcare provider to set realistic goals helped me get to where I am today, which is exactly what the next hour and a half will help us all do together. Our expert guest, rheumatologist Dr. Christopher Collins from the MedStar Washington Hospital Center and Georgetown University, will help guide you through how to manage various aspects of rheumatoid arthritis, from disease basics to set impactful goals to help you thrive. Events like tonight are informed and driven by patients like you. With your input, the Arthritis Foundation can create more educational tools, resources, and programs that will speak to what's really important to you and help you live your best life. A short video with you to tell you about our Insights program so you can make your voice heard and help us create more programs like this one.
By taking part in the Live Yes Insights Assessment, you help change lives today, including your own. And you help change the future of arthritis. It takes just 10 minutes or less to share your experience and make a difference. Answer simple questions like how often you felt arthritis pain in the last week. Ongoing insights data from people like you will lead to new resources that ease daily life. Your insights show what kind of support you need in your community. You improve the healthcare system. You focus researchers and others on top priorities. You'll make more research funding possible, leading to new groundbreaking treatments. The power is in your hands to change things now and for the future. This is your opportunity to change the future of arthritis.
So before we dive in, I have a little housekeeping to share. We have muted all attendees to this event. You can direct any questions you may have throughout the box on the bottom of your screen. And our presentation tonight will be broken down into two major paths. Our first path, or the first part, is a better understanding of RA. And the second part is designed to help you better manage your disease and improve your healthcare experience through a series of mini lessons. These lessons will teach you how to track your symptoms and help you learn about how RA affects you, how to come up with actionable goals to help you better manage your disease, come up with an individualized treatment plan. We'll also brainstorm goals together so we can walk away with realistic, applicable ways to help you manage your disease effectively. After tonight's session, you'll receive an email about your experience tonight. These surveys help us track sessions and better plan for future events. But before we begin, let's take a minute to learn more about who's in our audience tonight. Please, link that is on your screen. And a few of our questions are how long you've had RA, you already belong to a support group, how are you feeling today? Give a few more moments. And thank you so much for providing your answers. We'll circle back in just a few. But now let's get started by introducing our guest speaker, Dr. Collins. Dr. Christopher Collins, MD, is an adult rheumatologist who most recently worked for the Division of Rheumatology, MedStar Washington Hospital Center, and an associate professor of medicine at Georgetown University Medical Center. Currently, he serves as the medical director for a pharmaceutical company developing therapies in lupus. While in academic medicine, he ran one of the largest lupus clinics in the DC metropolitan region, as well as several inflammatory arthritis clinics. Prior to joining the hospital center, he was a senior research fellow at the National Institute for Arthritis and Musculoskeletal and Skin Diseases, NIAMS, at the National Institutes of Health. Dr. Collins.
Thank you, Barry, very much. So we were getting a little bit of in and out with you, Barry, on audio. I'm hoping in the chat, can you guys hear me well, or am I also cutting in and out? Let me know. Somebody tell me in chat if you can hear me well, and I'll kind of keep blathering away until somebody tells me they can hear me. But we can also just start with the first slide. That's my ugly bug. There we go. All right, so somebody let me know in chat if you can hear me and if it's pretty clean. Good audio. All right, so chat is disabled. All right, so we're good to go. We can hear. All right, fine. Nice. Good evening, everybody. This is, I think this is my 6th time to do this, so it is a lovely opportunity to meet everybody again. These are tough times. Generally, we've done these things in person. It's very engaging. We're learning to adapt, right? These are different times, and certainly we have adapted this presentation, as well as actually some of what we're presenting, to these COVID times, and hopefully we can engage still to the same level that we would have had we been in a large room together having a nice dinner. And so what I'm going to do for you is kind of walk you through a little bit about what rheumatoid arthritis is and how it differentiates from some of the other types of arthritis we see. And then we'll try to transition into this Live Yes program and what it can offer our patients. And so the first question here on the slide is, what is rheumatoid arthritis? And so what rheumatoid arthritis really is kind of the stereotypic arthritis that is driven by autoimmunity. And so what I mean by this is that there are a number of things that the immune system is responsible for. The immune system is responsible for protecting our body from viruses and bacteria and all the things that can happen and protect ourselves. But every once in a while, the immune system kind of gets out of whack. And instead of targeting viruses and bacteria like it's supposed to, instead turns in on itself and targets your own tissues. And so there are a ton of autoimmune conditions, type 1 diabetes, for example, multiple sclerosis, for example, lupus, others. Rheumatoid arthritis is one of those as well. And it's where the immune system, instead of just behaving like it should, instead, somehow, there's a lot of debate around where this happens, and it's different for different people. But instead of, thinking everything's happy, suddenly decides that what's going on in the joints shouldn't be there, and it starts attacking them. And so that's an autoimmune disease. And when it's a rheumatoid arthritis, it's specific to the joints. Now, how it differentiates from other diseases is that in arthritis, when we talk about it, it's kind of a global concept. Arthritis, when we think about our grandparents, they all complain of low back pain, a little bit in the knees and hips and stuff. This is a small joint arthritis. And so it tends to happen much younger in age, typically in their 40s or 50s. And it tends to affect more the wrists, sometimes the elbows, the ankles, the toes. And this is a very high inflammatory related type of arthritis. And so you get a lot of early morning stiffness, you get a lot of joint swelling and a lot of pain. And the problem is that if we don't treat this, that inflammation unchecked can cause damage. And this is really why rheumatoid arthritis has become up to the forefront in arthritis, where we can effectively provide new treatments and recommendations. Let's go to the next slide. So how may arthritis, specifically rheumatoid arthritis, affect your health? Well, as I alluded to, the inflammation, and this is much more than you hear on kind of, oh, I'm a little bit inflamed. This is like a hot forest fire going on in your joints. That forest fire going on in your joints can cause permanent damage, and we can't undo it. And that permanent damage can result in cartilage loss, and if it gets underneath the cartilage, it can result in bone loss, and that can result in deformations and narrowing of the joint space itself. And that's a big driver of mortality and morbidity for a lot of our patients. We can get some collections of inflammatory tissue, we call them rheumatoid nodules, that can occur in the skin, actually occur in a lot of other places like the lungs. And then in the heart, because inflammation, and we've learned this over the past couple of decades, inflammation drives increased cardiovascular disease. So when we talk about things like strokes and heart attacks, that's actually inflammation of the blood vessels that increases plaque fragility. And so patients with rheumatoid arthritis, unfortunately, have a much higher rate of cardiovascular disease than patients who don't have rheumatoid arthritis. Finally, we also see extra articular manifestations that spread beyond the arthritis, including, obviously, we talked about the lungs and the skin of the heart, but also eyes. I mean, we don't really think about this, but we call this secondary Sjogren's. So a lot of patients, upwards of 60% of patients, will get a very dry eye syndrome, which can also result in cataracts and glaucoma formation. Next slide. So, the next couple of slides we tossed in here because we are in a new era. We are in the COVID, basically, that this is going to be where we are, honestly, for the next few years, at least, until we get some collective endemic kind of status. The idea is that this is going to be something that if you are living with rheumatoid arthritis and you are on immunosuppressive meds, you need to be more aware of. And so I want to talk a little bit about how this can affect you, and it's not going to be everybody. The one thing about rheumatoid arthritis I want everyone to realize is that it's not one size fits all. Not everyone has RA that's the same. There's going to be 100 people with rheumatoid arthritis, and 99 of you will have very variable diseases. But we know that some patients with rheumatoid arthritis can get a lot of extra articular disease, especially in the lungs. And so patients with rheumatoid arthritis can get inflammatory diseases in the lungs. They can get some airway disease from the bronchioles that are too wide or too loose and cause a lot of mucus. They can get nodules, and we talked about these little collections of inflammatory cells that occur normally on the skin, but they can occur in the lungs as well. And pleurisy, I mean, you take a deep breath and it hurts, as well as an increased risk of infections. And so this all sounds very confusing. It all sounds very scary. And I don't mean to scare anybody around this. But I want you to realize is that having rheumatoid arthritis can also, for some patients, also have a lot of lung manifestations. And I want you to be aware of that. And the idea is that not every time you have a little bit of pain when you deep breathe, it's going to be COVID or pneumonia or whatever. But understand that these are the things that you need to have conversations with your doctor about. Because rheumatoid arthritis, as much as we like to say it's just arthritis, can have lung effects. And so just be cognizant that that can happen. And these are things to engage in conversation with your clinicians and your rheumatologist about. Next slide. So what are some of the overlapping symptoms from, say, overt lung inflammation, whether or not it's from influenza or COVID or something else? Obviously, things like shortness of breath, cough, fatigue, fevers. The problem is that those can also be seen in rheumatoid. So you want to really understand what's going on. And that is really inherent to have a conversation with your clinician. I encourage all of you to have a really good relationship, if not with the MD in the practice, at least with the nurse practitioners, the office staff, and everybody else. And none of them mind if you call them up with symptoms and say like, what's going on? I need to know what's going on. They'll help you walk through some of this, right? But what can you do outside of your diagnosis and in the setting of something like COVID? Well, you protect your lungs as well as you can. So don't add insult. First, don't smoke, right? And this is not just tobacco, it's also vaping, it's unfiltered marijuana, it's all these things that if you introduce inflammatory crap into your lungs, it's going to be hard to understand what's causing the inflammation. And that's going to be driving uncertainty for you and the clinician as to really what's going on. Second, get regular checkups, right? When you have a diagnosis like rheumatoid arthritis, and we know, and again, it's a small subset of patients who can get lung involvement. And the good news is that 95% of patients with rheumatoid arthritis will have no lung involvement. But it's that 5% we don't really understand and we can't predict, unfortunately. And so have regular checkups, monitor the lung functions and check X-rays and things like that, and talk to your physician about that. Certainly, we all feel that better controlled rheumatoid arthritis is going to be a better long-term outcome, including a reduction in likelihood of getting these extra articular manifestations. So follow your rheumatoid arthritis treatment plan that is designed to keep you in remission as much as possible. Next, keep up to date on your vaccines. In the United States, they are expanding, and certainly anybody with a disease like rheumatoid arthritis is eligible to get a booster shot. So I understand there's a lot of concerns and a lot of misinformation out there, and I'm not trying to politicize any of this. But when you have something like rheumatoid arthritis, I encourage you as much as possible. And the people that are within your field of exposure, get vaccinated. And now that we're understanding how these vaccines work and how long they last, consider strongly getting that booster 6 months after the last one that you got. Consider getting that booster done, because when you have a chronic disease like rheumatoid arthritis, which can affect immune cell responses, and when you're on medicines, which also can affect your response to vaccines, these are more important than anything for all of our patients. And finally, if you have any symptoms, honestly, if you just have any symptoms that you're concerned about, but especially if you have lung symptoms, shortness of breath, a severe cough, wheezing, things like that that won't go away, contact your physician, go to the emergency room if you're unsure. I would encourage everyone to go on Amazon and get one of these home pulse oximeter. They're like $20. You can measure your pulse ox on your finger. Anytime it drops below 95 or 90 especially, call somebody, get some help and guidance on what you're going to do next. Next slide. So let's talk about a little bit about how we treat rheumatoid arthritis. So, the baseline treatments are non-steroidals. These are things like ibuprofen and indomethacin, and they kind of help, symptomatology-wise, and I actually use them as a little bit of a surrogate of how patients are doing overall. My goal is to get your arthritis under such well control that you don't find the need to use any non-steroidal anti-inflammatories. If you still are using a lot of them, sometimes it suggests to me that we need to treat you a little bit differently. Corticosteroids, this is prednisone. If you're on prednisone, most of the time, I hope if it's for not rheumatoid arthritis. If it's for rheumatoid arthritis, you got to talk to your clinician and say, like, why am I still on steroids? Steroids are still useful for a lot of things. I've already seen in the chat box that there's a number of patients with overlap disease, like mixed connective tissues and lupus, and those still unfortunately remain part of the regimen for these diseases that we don't have such great treatments for. But now that we have some really great stuff for rheumatoid arthritis, corticosteroids in this setting, outside of a very short period of time, really should be relegated to kind of the backbone of what we are giving to patients. So conventional DMARDs, this is where we have existed for honestly decades, and they are and still remain the front line of therapy. And these are drugs like methotrexate, azathioprine. Many of you have already heard of many of these. These are the pills, right? And the truth is that honestly, for a majority of patients, not all, but 60-70% of patients, these are perfectly fine. And you don't necessarily need to go to one of these kind of biologics or JAK inhibitors. I'll talk in a second. But don't be surprised if you're a new diagnosis or if you're on it, that these are the drugs that we still look to as the backbone of conventional therapy for rheumatoid arthritis. Now, these days, we kind of look to these as a stopgap and say that, let's see how well you can do. We look for 3 to 6 months and how you respond to it. And the truth is, if you haven't gotten to where we want you to go, there's an increasing willingness to jump to some of the more potent medications, as well as an increasing willingness of the insurance agencies to pay for it, to go to the more expensive agencies. And these kind of really have been the renaissance of rheumatoid arthritis. And they're game changers, right? Not everyone needs it. But before they existed, the people who didn't have access to them, they were the ones that just ended up on terrible disability and we couldn't do anything about it. But around 15 years ago, we started really adopting the use of biologics. And this is the Enbrel, the Humiras, the Remicades, the Rencias, all the new ones. I mean, I've lost track almost of how many of these new ones are out there, including some oral pills, which we call the JAK inhibitors. And there's baricitinib and ubinetazimib and others, which are all very, very potent, many of which are recommended in combination with some of those conventional DMARDs. And so, it's like a kitchen sink, and your rheumatologist is a chef, right? And so you work with a rheumatologist to understand what's the best recipe for you. And that recipe isn't always just what's the most efficacious. The recipe is also what's the best tolerated, what has the lowest side effects. It's what's individualized for you. And so there is no one size fits all. I want everyone to appreciate that when you are talking to your rheumatologist and you're like, well, I heard something on TV or somebody said something else. The rheumatologist is thinking about you as an individual. And that as an individual is going to be a little bit of we don't know exactly. We're going to try this. We're going to try that. We're going to figure out what works best for you. Now, 10 years from now, I hope that we're going to be able to just do maybe a simple blood test and be like, I know what's the best combination for you. And that's going to work for you. We're not there yet. So there's a little bit of play. A lot of you have probably been on this call and have been through a number of variable changes in your medication. Understand that that's just where we are. As much as great things that we have produced, we don't really understand whom is the best candidate for what just yet. We're getting there, but not yet. Next slide. All right, so let's move on to a little bit about self-care, right? So what should you know? So first of all, regular physical activity is incredibly important. These are kind of the background things that you can do as a patient to help yourself, right? As much as clinicians, and especially in Western medicine, love to like chunk out pills and these expensive meds, there are things that you can do as a patient as well to help improve your overall fitness and ability to deal with rheumatoid arthritis. And so things like low impact aerobics. And so, we talk about, what's a good type of fitness activity for patients with severe arthritis. Well, ideally you want your arthritis to be controlled, right? If it's super inflamed, super flaring, obviously you're not going to go do a bunch of running. If on the other hand, it's doing quite well, you're going to want to consider, well, what are the things that are joint safe? And so if you are a professional runner and you have good form, that's fine. If you've not run before, well, it can sometimes actually, impact a little knees too much. And so maybe something like aerobic exercise from one of these elliptical machines, right? And so it's a little more fluid. You're not going to do these kind of heavy impact things, and we call them low impact. And that's going to work really on strengthening and flexibility. If ultimately you're having challenges deciding or understanding what's the best thing to do, get your clinician to get you a physical therapist. Most insurances allow physical therapists for a significant period of time in a given calendar year. So definitely take that on and look at that as an opportunity. Next is diet. This is a huge one. I mean, when I was a clinician, patients love to ask me what is a good diet for rheumatoid arthritis. And so the answer is, unfortunately, there's not a lot of funding for diet in rheumatoid arthritis or diet in anything, because most of the clinical trials that are done are funded by pharma, right? So you don't get somebody who produces a food product funds a large multi-randomized clinical trial in rheumatoid arthritis. That being said, there have been some NIH-sponsored trials that have looked at specific diets and specific types of arthritis. And I will tell you that at the end of the day, the baseline recommendation is that if you have an inflammatory arthritis, try to optimize anti-inflammatory foods. I encourage you to just go to Google and type in anti-inflammatory foods. It's mostly going to be omega-3 fatty acids, some things around certain cherries and nuts and stuff like that, and avoidance of pro-inflammatory foods. So pro-inflammatory foods would be highly enriched products, so white rice, white bread, things like that. My advice to my patients before used to be, if you read an ingredient list on a product and you don't understand, or if you can't pronounce half of it, understand that the body was probably not meant to digest it. So as much as possible, try to go for those foods that don't have a lot of preservatives, that haven't been enriched highly, and you're probably going to be okay. Well, what do you do when you have an inflamed joint? Well, heat and cold baths are pretty great. So in general, if it's super inflamed, I like cold, right? So think about a sprained ankle. You don't put heat on a sprained ankle, you put cold. You want to reduce the inflammation. If, on the other hand, it's not super inflamed, but just chronically painful, think low back pain. Heat, that's going to kind of relax the muscles that are often irritated around that. And so you can alternate these 20 minutes on, 20 minutes off, and just kind of think about what's driving the pain. Is it super inflamed, or is it just chronic pain, but not inflamed? Next, balance activity with rest. And so think about your limits, and these can change. This isn't like you have to decide 1 year, this is what I can do, what I can't. These are an evolving process. Don't overschedule yourself, but don't overdo it. Take breaks for the day, prioritize good sleep habits. You can Google sleep hygiene. You get a lot of great recommendations from that. Finally, manage emotions with mood. Find ways to ease stress and anxiety. Develop a support network. I mean, you guys are all on this call, which is a great, and this is kind of the ideal thing that you're going to help moving forward. Next slide. CBD and supplements. All right, we get a lot of questions about these. We don't have a lot of data, unfortunately. The top two bullets are always the most important. These are not considered substitutes for disease-modifying medications. Maybe they can be augmentary, but they're not substitutes, right? So you shouldn't say, oh, my doctor said I should take this biologic plus a DMARD, but you know what? I'm going to drink a lot of green tea and ignore their recommendation. These are not substitutes for disease modifying. They may be, or may not be, who knows, beneficial as an add-on, right? But at the end of the day, and this is the second bullet, always just talk to your rheumatologist. We are, as a subspecialty, pretty open to patients looking at variable options to help control the arthritis. And the truth is, it's because we don't know what is individually going to work versus not. The clinical trials that have been done are all kind of like, who knows? None of them are very well controlled. I and every rheumatologist out there has anecdotal evidence of patients who have responded to things like fish oil or turmeric or CBD. All of us have had patients who said and swear by them, and we can't fault them for it. But we just want to make sure you understand that there are some limitations to all of these things, right? So most of the things that are listed here are not controlled by the FDA. So ergo, that there is some variability in commercial products. And so do your research, understand whether or not there's some supplement that has some sort of quality control associated with it, and see how people are doing it. At the end of the day, as long as you and your rheumatologist agree that these aren't going to be harmful, I love these things. CBD, same way, and this would include medical marijuana. Again, talk to your rheumatologist, make sure that there's no other things going on. For me personally, medical marijuana I'm fine with as long as you don't inhale it, because again, it's something that you're inhaling that can cause inflammation. I think edibles probably are a little bit better, but again, talk to the rheumatologist, make sure they're comfortable with this. Let them know that this is where you are in this space, and that you recognize that these are unregulated and very, very weakly studied kind of supplements. Next slide. All right, we're going to pause here, and I'll take some questions.
Dr. Collins, can you hear me?
I can.
Awesome. Thank you so much. And thank you for diving into some of the details, a little bit more detail. We did have a couple of questions. The first question is pretty popular. I've heard it in the past. And the first question is, what causes medications to lose effectiveness over time, which then forces you to switch?
Yeah. So, it's a good question. So the first of all, we hear about things like people who go on, say, opiates for pain control, and that over time those opiates tend to lose their efficacy, and that's because of something called tolerance. In rheumatoid arthritis, it's actually very different. We don't see tolerance actually with any of our medications. What likely is happening is just an evolutionary change in the arthritis itself. And so where the arthritis is at one point and seems to have responded to some medication, now 5 or 10 years later doesn't respond as well, doesn't mean that the medication suddenly lost its efficacy because you became tolerant to it. It just became, your arthritis got more severe, or something to the nature that it just isn't the right medicine for you anymore because your arthritis has changed. But we don't see, with rare exceptions, somebody who has a medicine who suddenly develops an intolerance or an inability to respond to it. Now, there is 1 or 2% of patients who are on these biologics who develop antibodies to them, for example, but that's pretty rare. My general sense is that, one, I think that arthritis evolves, and that's unfortunately something science hasn't been able to address consistently. And two, our expectations honestly change. We went from I was feeling awful to I feel great, although in hindsight, I probably could have felt greater. And now that I don't feel as great as I think I should, maybe is that a sign of I'm not feeling worse, or is I think I can do better? And that's fair. It's honestly fair. The paradigm for how arthritis should be treated in the 20 years that I've been practice has shifted from, God, I hope you feel a little bit better, to I expect you to be in remission, right? And so I think patients are sensing that as well. Yeah, that's a complicated answer to a complicated question.
Appreciate that. We have another question, and one of our participants would like to know what specific blood markers should be tracked over time so that they can see progress of the disease.
Yeah, so it is a combination of both blood, but mainly clinical markers that help us determine how patients are doing. And so there have been a number of different kind of forms that you will fill out in the clinician's office that have been validated to correlate overall with how well you're doing. And many of them are a combination of both clinical symptoms, and this is things like how much morning stiffness do you have? How do you feel? What is your level of activity? Plus a clinical examination of tender and swollen joint counts. And finally, the markers for blood, to get to your question specifically, that we consider are the inflammatory markers of what we call a erythrocyte sedimentation rate, or an ESR, or a CRP, which is another inflammatory marker that a lot of clinicians use. So the blood test, I would consider ESR and CRP as surrogate inflammatory markers, but yeah, they're pretty non-specific. I mean, you can have a urinary tract infection, for example, and those will go sky high. They won't at all tell you how your arthritis is doing. But when you place them in the context of how your arthritis is doing and how you feel overall, based on some of these markers like the RAPID-3, and we'll talk about some of this later on, those are the markers that I would encourage you to work towards to help resolve and talk to your clinician about.
Makes sense. Thank you. And we do have a third question. Please explain rheumatoid nodules. Also, can RA cause skin symptoms or cause sun sensitivity?
Yeah. So rheumatoid nodules are little collections of inflammatory cells. We don't know why some patients get them, some patients don't. They can occur in a lot of different places. Classically, they occur over the extensor surfaces over the hand and elbows. And so these are along tendons, right? And so tendons are the things that kind of pull joints up and down. So they can occur sometimes in the hand. A lot of patients will get them along this area as well. And then some patients can get them in the lung, oddly enough, and they're just little collections of inflammatory cells. And sorry, what was the second part of the question?
The second part of the question asks if RA can cause skin symptoms or sun sensitivity.
So indirectly, skin symptoms. Yeah, so rheumatoid arthritis can have a lot of secondary arthritis symptoms, including vasculitis. So you can get little blood vessel breaks and inflammation of the blood vessels that can happen in patients. Obviously, patients on the skin, that's where we see the rheumatoid nodules. As far as how to treat these things and what can we do about them, we treat these patients as best we can. And I'm sorry, the last part of that question was again
About being sensitive to the sun.
Yeah, sun sensitivity. So I think that everyone is a little sun sensitive, right? I think that rheumatoid arthritis in general occurs more commonly in Caucasian individuals versus African American patients, but that's not it alone. I think that there are a lot of other medications that we traditionally take which can increase sun sensitivity. So if you are on methotrexate, which if you have rheumatoid arthritis, I imagine 90% of you have heard that drug before. Concomitant use, meaning if you take it at the same time with a drug called Bactrim, which is also probably the single most common drug used for urinary tract infections. That combo can increase sun sensitivity and cause some rashes. Not in everybody, in fact, probably not in most people. But understand that if you are in methotrexate and somebody prescribes you Bactrim, have a conversation and say, hey, I'm on methotrexate and I have rheumatoid arthritis. Maybe I'd be on something different. Yeah.
Appreciate that. And just to let our audience participants know, we are going to have multiple additional Q&A sessions, but just to keep the wheels on the bus going round and round, perhaps we can continue forward, Dr. Collins. Does that seem fair?
Yeah, that's fair.
Awesome. Thank you.
All right, so let's move on to living yes with rheumatoid arthritis. And this is kind of diving into what can the Arthritis Foundation help you with in managing your rheumatoid arthritis. So lesson 1, health tracking. Next slide. So as a clinician, I ask my patients to help participate in their kind of care. One of the things that I like best is when they are monitoring how they do outside of when they come see me. And the truth is when I see you, I got 10, 15 minutes at most. And you have a list of questions. And, if you've not prioritized them, sometimes things like just health tracking get missed. And what I'm really interested in is not how you're doing at the moment that you see me. And all of you, I promise all of you, have shown up to a doctor's office and said that, oh God, every day before this, I felt terrible, but today I'm okay. And the doctor's like, yeah, you're okay. And you go back home and you feel like nothing was done. And so monitoring how things have actually been doing over time is actually very beneficial, right? And so how things are at the day that you show up to your doctor may not reflect how really you've done overall. And so we encourage patients as much as possible to track and record the symptoms that you have regularly. And so what we're going to talk to next is about what can the Arthritis Foundation provide to you around how to track some of those symptoms. Next slide. So first of all, what can be tracked? Well, you can track pain levels, and clinicians think about scales of 1 to 10, sometimes 1 to 3, and you can kind of really mark day to day what is your over pain level. And again, it doesn't mean if you have a bad pain level that suddenly your arthritis is bad under control. We will look these things globally. We understand that if you sprained your ankle, your pain level is going to be up. It's not going to necessarily reflect an overall bad measurement of how your rheumatoid arthritis. But we want to understand in general how your pain level is. And as much as you can, when you track things specific to a diagnosis, we want you to track the pain level around what you think your diagnosis is contributing to it. For example, if you banged your knee one day and your pain level is a 10, well, don't record your overall pain level as a 10. Understand that that's a little separate, right? Think about, what's my overall rheumatoid arthritis pain level? And that's what we to record, because that's going to be the more meaningful level that when we look at, when we talk with you about, is going to help us make some of these decisions. Second, sleep patterns. Sleep is one of those things where none of us ever get enough of it. But sometimes disruptions in sleep patterns can be suggestive of what's going on overall. And this includes mood and other things as well. We want to know what your water intake, what kind of food choices you're making. We kind of alluded to this earlier. I mean, do you stare at something orange and say, "Oh, those are carrots," but after you've chewed them a lot, you're like, "You know what? That was my kid's Cheetos." Just tell us, right? We want to know so we can help you make some of those choices better. And then finally, other symptoms and what's going on, because we do acknowledge that rheumatoid arthritis extends beyond just the joints. What is your level of activity? Are you able to walk a block? Are you able to walk a mile? Are you able to run a marathon? These are all things that are very telling in how patients are doing overall. And this includes something even just as basic as how well you can do basic activities of daily living. Can you comb your hair without having a significant amount of pain? Can you get up without having to sit in a shower for hot water for 20 minutes? Can you cook dinner? These are the things that help us understand how well your arthritis is controlled. Next. So there is on the Arthritis Foundation website something called a Better Living Toolkit. It is a toolkit that is designed to help you learn about your disease, and it includes one of these health trackers that asks some of these things that you can then input, keep on your phone, and then show your clinician when you show up into your practice. We'll talk a little bit about setting goals as well as communication with your doctor. But overall, that this Arthritis Better Living Toolkit is an extremely useful tool for all of you to be aware of. Next slide. One of the things that we use in the health tracking is something called a Rapid 3. This is a well-recognized clinical tool amongst clinical practices. Most clinical practices, especially in the private practice sector, utilize the Rapid 3. And this is a very good correlate of how well your arthritis is doing overall. You'll take a survey which will assess your functional status, your overall pain level, overall well-being, and you'll get a number. And those numbers correlate very well to a clinician about how well you as a patient are being treated. So it's not all just numbers and x-rays on the lab and on a radiograph. The importance of how well you're feeling actually does really, really well. All right, next slide. All right, so I think we're gonna take a poll here in a second. The questions are really kind of, what do you currently track? Are there any areas of your life that you think should start tracking, and what are they? Oh, there's no poll. Well, how about this? How about can we open up chat a little bit? Let's go back a little bit. All right, let's go back one slide. So, all right. I want to see in the chat, if anybody tracks symptoms, what are you tracking? And I'll watch the chat as it comes up. Barry, you can help me out.
Happy to help. I think the number one item is that we have folks that are tracking pain.
Yeah.
Swelling. We have one comment that's tracking weight, exercise, food, and pain levels. That's aspirational for me. I'm not that responsible unless I'm in a flare-up. Sleep, location of pain, pain and fatigue. We have folks with exercise,
So I
That's
have a question. So my next question is, how are you tracking it? Or do you have an app? Do you just keep a diary? Yeah,
Let's
how
find
can
out.
I like that? How can you track fatigue? It's a good one.
So it
I
looks
think
like we have
I think
a few folks are using their apps within their phone. So whether it's an Android or an Apple app, the
and
memo
do
app on their phone.
and is this an app that you then share with your clinician when you show up to your visit?
For me, I do. I actually use the Track and React app, and I also, if I'm in a flare-up, I have a pretty robust spreadsheet that I'll keep that I can download and then make modifications from there. But it sounds like looking quickly through our chat, we have quite a few folks that are using apps, and I would challenge that. Do we share the app results with our clinicians? Is that what we're doing for the most part?
I think it's great if you do, honestly. When I was in clinical practice, if somebody
Or just
showed me an
send
app on their phone,
practitioners?
I just loved it. It was so helpful. I mean, generally these things come with ability to track things and graph them over time, and you get a real sense, right? We could sometimes pinpoint to a flare and be like, what happened here? And sometimes you had no explanation. You're like, God, maybe that was really the arthritis, and we had no idea. But other times it was like, you know what? I went out of town. I went to Cancun. I had a bad sun, rash, and I flared. And we're like, all right, I understand. Next time we'll do better with sunscreen, and we don't have to necessarily change meds. So tracking these things, honestly, is extremely
Absolutely. We have an overachiever that shares Fitbit tracks with the Vim app, which I love. I'm a big fan of the Vim app.
nice. There's such great comments coming in. Perfect.
It's great.
So
It's almost like we have so many
I
angles to
know.
provide information. How do we
I
compile
know.
it and make it tell a story?
So one of the things as clinicians and people that are out there developing these things, are there things that you wish we tracked that we don't? I mean, are there any areas of your life that we should track better that you think are important? I'm just curious. Stress.
Stress,
Ah, that's a good one.
absolutely.
What do you do for somebody
Anxiety.
who, yeah, anxiety? What do you do for somebody who minimizes their pain? Oh my gosh. Well, try not to minimize your pain. It's probably a woman. I can't imagine. You guys are tough nuts, man. Men are babies. Um, I encourage you, if you have pain, just talk about it, right?
Another one, I
Oh,
saw
brain
medication side
fog.
effects.
Oh, that's a good one too. I do think that I think some of the apps out there are pretty good about recording side effects. Um, so search those out. I do think those exist. I think some of the ones around stress, brain fog, and memory lapse. I think that's a great one too. To be able to record those. My recommendation for all of you that find a lapse in whatever it is you're tracking, for example, on a smartphone or a computer that you don't think is captured. Also, keep a written journal to record some of these things, especially if it's something that's really driving a problem for you. Because even if they're perhaps not captured in electronic format, it doesn't diminish their importance. And I want you to make sure that you bring them up with your clinician. Um, and certainly it's something that I think is worth exploring further. So
I'm
brain
not sure if
fog,
we should
yeah.
dive into this, but I saw something that definitely sparked my memory when I was first diagnosed, which is what is the difference between RA and a side effect? And being new, how do you distinguish between
Yeah.
is a symptom and then what is a side effect?
Yeah. So the good news is that the majority of side effects from all of our medications are minimal. And they are limited to kind of things that you would normally expect with normal medications. Anytime you swallow a pill, expect a little bit of occasional upset stomach, occasional diarrhea, occasional headache. Anytime you get an infusion, sometimes expect a little soreness and redness around the infusion. Beyond that, it really involves just having a conversation with your clinician who understands you better than anybody else. Most people whom are getting a medication for their arthritis should have improvement in their arthritis. And then if they have a side effect that they can't explain beyond that, have a conversation. Talk to your doctor, talk to the NP, whomever is there at the practice that you're at. Without question, these are potent medications. And without question, a non-insignificant number of patients have side effects. The fortunate thing is that most people don't. Or if they do, they're tolerant. But understand what the spectrum of side effects could look like. Understand what an infection could look like. And talk to your doctor. That's all I really have to say about those. Yeah. All right. So we are a little bit behind. Let's move on to goal setting. Lesson number 2, next slide. So I like patients to think about goals, and this kind of allows patients to think about what is achievable and realistic, and allows them to set a prospective ideal where they want to be down the road. And so there's both personal goals and medical goals. There's whether you're, say, a hobbyist who likes to paint, you want to keep painting, or you're a runner who wants to keep running. Maybe you like travel, you want to keep traveling, volunteering, you have a certain level of physical activity, or perhaps it's just basic medical goals. You want to just feel better, reduce the number of tender swollen joints. You want to make sure you're doing better at adherence medications. How can we improve goal setting? And there are tools within Live Yes RA program. Next slide. So the first is understanding how to set the right kind of goal, right? And so there's a mnemonic, we call this SMART. This is a goal that has certain elements. It is S for specific, so you want to know exactly what it is you want to accomplish. It's M, measurable, that you have concrete steps to practice and track the progress. It's attainable, that you know it's within your reach. You're not just kind of going high in the sky. It's relevant to you, that it's reaching it is meaningful to you, and it's time bound, right? You're not just saying, one of these days when I get to this. It's you have a specific end date that you work towards. And so, for example, a SMART goal would be, I used to be a runner, and I participate in my kids' 5K every year, but my arthritis is really limited. I would like to be able to participate in my child's 5K next year. And so you have 12 months, time bound. It's relevant because it's important to you. It's your kid's 5K. It's specific. You know exactly what to accomplish. It's measurable. You know how you want to get there, and it's attainable. You know it's within reach. And so next step is really, how do you get to that point? And so you talk about it. And next slide and see what it shows. It didn't get there, but the idea is that you get there incrementally. Like you start and you say, this month I'm gonna do 1K. I'm gonna try to do it in 2 hours. And then the next week, all right, I'm gonna do 1K, but I'm gonna do it in 1 hour. And the next time I'm gonna do 2Ks, and so on and so forth. And so you've set yourself goals. You've set yourself realistic expectations. And the idea is that eventually, and this is part of the conversation you have with your rheumatologist and the people treating your arthritis, is like, if you can't get there, it's because your arthritis I don't know, maybe it could be better controlled. You have to understand what are the limitations. If it's inflammation, is it just damage? You want to understand what it is that are the limitations, but you have a goal in mind. When you talk to your clinician, they'll work you through. And so the next exercise is really in the chat box. I want to hear what are some of the goals that maybe you have, and are they smart? And again, I don't want somebody to say like, oh, I want to be able to shop more, or I want to go to Europe one day. You have to have some specific goals and think about the specifics of it. And so I'm looking for just a few chat, and we can talk about some of them. What do you think is a goal that would fit into a smart kind of algorithm, if that makes sense? Barry's going to write some of these down. Thank you, Barry. Everyone's busily typing, which is great.
It seems like we have a lot of ideas for some great goals.
No, I can imagine, right? All right, so while people are writing it, I'll start with the first one. I want to exercise more. So
And Dr. Collins, let's just pause for a moment and have
Yeah.
our attendees put their goals into the Q&A.
Yeah. So while they're doing that, I just want to talk about this first one so it can help think about what people are typing in. I want you to be a little more specific, right? I want to exercise more is a great concept, but maybe a smart goal would be, I would like to do 30 minutes of exercise a day, 3 days a week within the next 6 months. Does that make a little more sense, right? You're setting a specific goal that you can track and monitor over time. And Barry, add to that 3 days a week and achieve this within the next 6 months. Right? So it's pertinent to the person. It makes sense. It's achievable. It's time-based. So think about a goal that is important to you. I did this once. I've done like 6 or 7 of these. I had a patient once who told me, I want to be able to wear high heels at my daughter's wedding, which is in 9 months. And I thought it was perfect, right? I want to play golf again comfortably at least 2 days a week. When do you want to achieve this by? I want to play tennis again. Again, thinking about realistically where you were before, where do you realistically see yourself, say, 6 months from now? These are the kind of smart goals we're talking about. Thinking about something that you can set forth as a goal to work towards, not just the end game. I understand the end game's important, but a smart goal is how you can document your progress to that point. Because at the end of the day, this is a conversation that you can then have with your rheumatologist to understand that if you're having limitations from your arthritis that inhibit your ability to achieve this, how can you get there? Is it through physical therapy? Is it through better arthritis control? Is it through something else? But have a goal in mind and how to incrementally get yourself to that point so that at the end of it, you actually achieved it. Nothing lofty, something realistic, and have a plan to do it. I love this. I want to work up to 7,500 steps per day by January 1st. Set a plan. Set that goal to get there by then. You want to
Dr.
play
Collins,
soccer.
do you suggest with setting SMART goals, setting like smaller SMART goals that lead up to a larger goal? So
I
like
think
your
that's fine
patient-
as well. I think that you can have goals within goals. I absolutely agree. And I think sometimes that actually helps because you don't get discouraged along the way if you haven't got to where. And so if say you want to get a BMI of under 30, well, if you started at say 40, say I want to get to 37 by 3 months from now. I want to get to 33 by 6 months from now. And I want to get to 30 by 12 months from now. Those are goals within goals, right? Same thing for all of these other things that are being listed here. I want to work up to 7,500 steps a day. Well, how about we start with where you want to be a month from now? Where do you want to be 6 months from now? Where do you want to be a year from now? And so, again, be realistic. Understand your body is not what you sometimes think you want it to be, and be forgiving of that. But I think it's great to have goals. Absolutely, it's great to have goals. And goals within goals can sometimes be extremely helpful. I see lots of great goals coming in. So, Barry, let me know when we need to move on for time wise. So, but there's lots of great stuff coming in on the chat box, I can see.
And Dr. Collins, why don't we move on? And I'm sure we'll have some additional great comments coming through in the Q&A.
Yeah, I agree. All right, so let's moving on. So there's a new app with the Arthritis Foundation called the VIM app. VIM is defined as energy enthusiasm, but to us, VIM means more. And what it allows for is kind of a tiered approach to helping you manage your arthritis. And first of all, it provides support. So everyone who's on this is somebody who is part of the arthritis community, and their encouragement and motivations and everything that is allowed through these kind of social networking kind of platforms. Support networks, honestly, are the best thing about anybody dealing with a chronic disease, is understanding you're not alone. And so having somebody there who can support you and understand what's going on, I think provides a tremendous amount of comfort for anyone dealing with a chronic disease. Second, resources. As a member of or a participant in something like this, know that the Arthritis Foundation is in the background making sure that you have the most up-to-date, helpful resources that are available to you and that are provided to you through a very neutral platform that is not induced by pharma, it's not induced by anything other than a foundation whose sole purpose is to be there and support you as a patient. And finally, improved quality of life. The app does some of the very things that we've been talking about. It helps you achieve goals. They kind of block them out in 6-week goals, helps you celebrate the small wins that help add up to these big victories, as Barry kind of alluded to, goals within goals. really to kind of help propagate you this kind of journey that you are working through to help improve your arthritis. Next slide. Finally, let's talk about healthcare provider communication. Next slide. So, as a former clinician, I have a limited amount of time with any clinician. With any patient, what I love to do is have patients who come in prepared with specific questions that are important to them. And I encourage you as a patient to be at the very beginning of any visit with a clinician, say, listen, I want to make sure that we have time to talk about some things that I have questions about. The physician has a specific, agenda as far as examinations and questions that they have to ask to do your overall assessment. But if you're upfront and say, listen, I have some questions and we'll talk about what those are, they will make sure that you have protected time. But don't spring them on them at the end. Be upfront, come prepared. And so the things that a doctor would like to know, especially if it affects you and that you want to talk about, are listed here. How arthritis is impacting your daily life and your relationships, how you're managing with your medications, what are some of the goals that we've talked about that you've set yourself, how some of the life's obstacles are maybe preventing you, and what you've done or plan on doing to overcome any of these obstacles. And the truth is, you may not have a lot of time, unfortunately, to talk about all of them, but prioritize them, right? List them in order and try to make sure your clinician has carved out a little bit of time to talk about the most important things on these lists that you want to talk about. Next slide. Next slide. All right, so how best to communicate? Be upfront, honestly. I mean, as a clinician, I'm not here to judge. Be completely honest. If you haven't taken your meds because life's been, a complete crap storm, we get it. We understand. And I'm not going to judge you on it. Be very open. Truthfully, the worst thing you want to happen is, your arthritis is not in control. We ask you, are you taking all your meds? And maybe you haven't been, but you say, oh, yeah, no, I take all my meds. And so suddenly they start messing around with stuff when the truth is, you just didn't have time. Life got in the way. And that's important to know. And so be upfront, be honest. We aren't judgmental. We may say, you should take your meds better. Don't take it as an admonishment. Just be understanding that we are trying to make decisions around what's going on with your life. And the last is be assertive. Don't walk out of a visit unsatisfied with what was said or a lack of understanding with what was told to you. If you are confused, demand a better explanation. If you are uncomfortable, demand a little bit extra time to get more comfortable. Be assertive. A good clinician isn't going to be upset about this. I, more than anything, appreciated patients who took control and were honest and knowledgeable about their own health care and were honest with me and really wanted to understand what was going on. I never had a patient that I had a problem with that fit that bill. So don't be somebody who just walks away and be like, well, I don't know what happened. I don't understand, because it doesn't result in good healthcare. Be assertive, absolutely. Next slide. So let's move on to the last discussion of HCP communication and review. And Barry, I'll let you lead this one, please.
Thank you. And actually, I believe we have a couple of questions before you step onto mute.
Dr. Collins, the first question that we have, if you don't mind, is how long can I be on methotrexate?
Okay.
Are there long-term effects
Yeah.
the longer I'm on MTX?
Yeah. So it's a great question. Methotrexate's been around for decades. Honestly, we've all had patients whom have been on methotrexate for 30, almost 40 years at this point. Most people who have a problem with methotrexate have it on pretty early. There is some data around long-term methotrexate exposure and some liver problems. Certainly, patients who have chronic liver disease or who have hepatitis or who are alcoholics certainly have a higher risk, for problems later on. But methotrexate remains one of the safest medications we have. And the majority of rheumatoid arthritis patients I've ever treated have been on methotrexate, honestly, for decades sometimes, with little to no problem. So I think it's a very, very rare phenomenon for patients to have long-term issues with methotrexate exposure at the doses that we use in rheumatoid arthritis, for sure.
Thank you. An additional question that came in asks about one of our attendees being asked about monitoring ANAs over time, but the rheumatologist said that they are only used to arrive at a diagnosis.
Yeah.
Going forward, there's not a need to continue the measurement.
Yeah, so ANA stands for anti-nuclear antibody. It's kind of a catch-all phrase. It's like saying rash. You don't really know what it means. In rheumatoid arthritis, ANAs can kind of be background noise. ANAs are one of a multitude of different tests that rheumatologists use to kind of complete a picture of what is going on. Anywhere between 30 to 40% of rheumatoid arthritis patients have a positive, generally low titer anti-nuclear antibody. That doesn't really mean much. ANAs happen, right? Anti-nuclear antibodies are one of these phenomenon that if we all get old enough, we'll all have. I think there was a study that said people over the age of 80, 60% of them had a positive ANA that had zero clinical significance. So ANA is one of those things that is very, very non-specific. If you had a very high titer, your rheumatologist would look further into it to make sure there was not something else going on. But a low titer ANA in the setting of rheumatoid arthritis is probably normal. And to the second point, it's one of those things that doesn't really change over time. It's kind of there, but the titers or how much of it's there doesn't necessarily correlate with, say, activity or one disease or another. So if you have a positive ANA, talk to your rheumatologist about the significance or lack thereof of it, and then move on from there. I don't think it's one of those tests that it's helpful when it's helpful, and it's not helpful more often than not.
Thank you. We have an additional question, and it asks how to personally monitor what the specialists are doing and be somewhat educated and active in my own health management.
Yeah. Well, honestly, it's a conversation with your HCP and understand what it is they're doing and why they're doing it. If they change a med, ask them why. Understand the med. Make sure you get lots of pamphlets that are provided when the medication is given to you, and you can understand the full side effect profile and stuff like that. Understand, well, I was on this and telling me I should be on this something different now. Why? So it's about communication. Honestly, it's just about communication.
Thank you so much. I believe that is the last question at this time. But Dr. Collins, I do want to truly thank you again for lending your time and expertise tonight.
Sure.
And speaking on behalf of our entire audience, that we're walking away with a renewed sense of confidence and empowerment to take control of our arthritis. And a huge thank you and
thank you.
Gratitude.
You're a powerhouse. Thank you so much.
You are far too kind. And over the past hour or so, we've learned so much, including the health effects of RA, possible treatments, how to better track our symptoms and how to set goals effectively, as well as passionately communicating as an advocate on our own behalf with our doctor. Even though I've had RA for some time now, I've definitely learned quite a few things tonight, including setting SMART goals and considering that goals always need to be challenging, yet attainable and measurable. So I guess putting it all together, some of the common themes from today that we're taking away is really taking control of our arthritis by better understanding our condition, by partnering with our healthcare provider, taking action, and by connecting and sharing our progress. And just as a friendly reminder that the Arthritis Foundation does offer several resources to help you stay on track and achieve your goals. We also have a supportive group of people who can hold you accountable, and that's a great way to help you follow through with new goals in the Live Yes online community. Our online community forums can also connect you to peers and experts, including healthcare providers, to ask questions and share experiences. In addition, we have support groups that are virtual and in person that will help you feel more connected to people who understand what you're going through. Much like an online forum, these support groups host quarterly informational events on various arthritis management topics, including sleep, nutrition, and alternative therapies. You can always learn more about our support groups and the online community at liveyes.arthritis.org. And if you ever feel overwhelmed or have a question that you need help with right away, you can always call our Arthritis Foundation helpline. Our helpline will help you navigate through the healthcare maze and even share resources about paying for treatment and care. And finally, if you have any additional questions or wish to seek for more information about your disease, there are 3 great places to start. The first is to talk to your rheumatologist. It may seem obvious, but your doctor is your partner in your treatment journey, and having an open and honest line of communication with your rheumatologist about various treatment strategies, complementary therapies, and pain management methods is the best place to start. And then by visiting arthritis.org, the Arthritis Foundation's website, it's full of content, tools, videos, and various resources to help you take control of your arthritis and thrive. We also have our local Arthritis Foundation market office. There's a local market office that will help connect you to programs and healthcare providers in your area, as well as connecting you with people with arthritis in your local community and informing you about local educational events. And for more information about how to navigate a new diagnosis, you may want to consider purchasing the book, Facing Rheumatoid Arthritis, A Guide for Patients and Their Families by Marcy Bolster, MD, and Theodore Stern, MD. And please note that in a couple of days, you should receive a survey asking you about your experience. I hope that you'll take the time to fill out the survey completely and honestly so that we can best serve you in the future. Your feedback indeed helps us to improve educational events to help with your needs and wants. And as a thank you to our sponsors, our event was independently created by the Arthritis Foundation, but a big thanks to our sponsors, AbbVie and Boehringer Ingelheim, for providing funding that helps make this event possible. I'd like to thank you all for joining and wish you all a wonderful evening. Thanks again.